that the 10-year breast recurrence or breast cancer-related mortality is higher than patients who are normal weight. When your patient gains weight while under therapy, these patients are deemed blessed to have less disease-free survival than patients who lose or maintain their weight at the time of start. And this is one of the more recent trials. This was, again, a couple of weeks ago in San Antonio. 2,500 patients who are ER/PR negative, because what we always told our patients is that your fat gives off the estrogen after most postmenopausal, but even in ER/PR negative patients, patients who reduced their fat in their diet did better, 13.6 years versus normal diet, which was 11.7, so they gained 2.5 years in terms of mortality reduction, 36%. If she was ER/PR negative, she had a 56% reduction. Now, if we look at all of this, this is actually exceeding what we give our patients in terms of hormonal therapy, chemotherapy, or even targeted therapy. So I think this is, if we get anything out of this lecture, it's please convey the message to your patients to lose weight. And thank you very much for your attention.
Thank you very much, Professor Mohsen. I enjoyed your lecture a lot, because this is the second face, the coin of pathology. Now, the last talk during this session will be by Professor Dr. Nagla Abdelrazek about the radiological evaluation of pathological complete response. Dr. Nagla.
Radiological, to end up this session, this is interesting about subtypes. Radiological evaluation of complete pathological response after neoadjuvant chemotherapy. It's published research. In Egypt, breast cancer is the most common among women, representing 18% of total cancer, 35% in women and 2.2% in men. In 2012, the age-adjusted estimated annual incidence of breast cancer, according to our results in the national screening program, was 2.1%. Primary and neoadjuvant chemotherapy followed by local regional treatment, either surgery and radiotherapy and post-operative systemic chemotherapy is now an accepted strategy. More than 70% of cases achieve objective response, including pathological complete response, which accounts for 10 to 25% of cases, and many patients experience downstaging throughout the primary chemotherapy. Breast conservation is possible in 10 to 40% of patients with locally advanced breast cancer. Pathological complete response. We defined in our research pathological complete response as complete disappearance of any invasive cancer cells in the excised breast tissue and lymph nodes after the end of neoadjuvant chemotherapy. The presence of residual DCIS or lobular in situ did not affect the definition of pathological complete response. What about radiological complete response? We define the radiological complete response as complete disappearance of the tumor radiologically, which is defined as radiological complete response and is not an indication of pathological complete response. Between 60 to 80% of patients who achieve radiological complete response have residual tumor cells found in the excised tumor bed, while we may find complete pathological response in patients with residual radiologic abnormality. Until now, many studies have shown that the physical examination, mammography, sonography provide suboptimal evaluation of lesion extent that do not allow accurate assessment of pathological response and residual tumor size. Many previous studies have shown that MRI is the most reliable technique in evaluating the residual tumor after neoadjuvant chemotherapy, although false negative with results with small volume tumor were reported. Based on that, we designed our study to identify the most sensitive clinical and radiological method to pathological complete response in order to help our patient management. So our study was designed to assess the complete pathological response after complete neoadjuvant chemotherapy by different imaging modalities, including digital mammography, high-resolution sonography, dynamic MRI, and MR spectroscopy, PET-CT, aiming to pick up the most sensitive modality. It's a multi-center prospective study, included 125 female patients enrolled in the study. All were histopathologically proven after core needle or after vacuum or after complete excision, and underwent full course of neoadjuvant chemotherapy, 3 cycles of FEC and followed by 3 cycles of docetaxel, and in HER-positive cases Herceptin were added. 25 out of 125, meaning that 20% showed complete pathological response after complete neoadjuvant chemotherapy, indicated by the absence of any histological evidence of invasive disease. The pathological complete response was retrospectively evaluated by different imaging modalities, including digital mammography, high-resolution sonography, dynamic MRI, including MRS and PET-CT. In all patients, metallic clips were lodged inside the tumor in order to facilitate the follow-up strategy. And preoperative localization was done for 18 out of 25 of the patients with complete pathological response. As you can see here, we have here the clip and this is the wire. In 7 out of 25, radical mastectomy was done for other reasons, including multicentric disease, extensive calcification, and inflammatory breast carcinoma. So, based on our results, we diagnosed complete radiological response on complete pathological response as absence of invasive disease in the breast and lymph node, and complete radiological response in mammography is defined as the absence of any lesion sparing the asymmetric density and the residual microcalcification. And for ultrasound, complete disappearance of the lesion. And for MRI, we define complete radiological response as complete disappearance of the image evidence of a mass, whether asymmetry, image evidence of a lesion, and disappearance, and based on the kinetic change from the kinetics washout curve to persistent type 1 curve. And for MRIs, complete disappearance of the previous choline peak detected before neoadjuvant chemotherapy. According to this classification, we categorize our patient into 2 groups. Group 1, including the pathological responders, and these are 25 out of the 125, and Group 2, which is the 100 with residual disease. I will give you the sensitivity of each modality in the 25 in the cases of pathological complete response. Among the 25 cases of complete pathological response, as you can see, we have complete evidence of disappearance of a lesion and complete absence of invasive disease. This to show the demographic data and the drugs and the medications taken and protocol of treatment. First, the mammography. 11 cases out of the 25, meaning that 44% of cases showed complete radiological response with no residual disease in mammography. As you can see here, we have a mass with a clip inside, and after a neoadjuvant chemotherapy, we reached a complete absence of a lesion. Here, in the rest of the 14 cases out of 25, more than 50%, 56%, residual asymmetric density was found in mammography. So when having residual lesion in mammography, this doesn't indicate absence of response. We encountered in 56% of complete responders residual asymmetric lesion. As regards the ultrasound, appearance, complete disappearance of an evidence of a lesion was reached in 17 out of 25, representing 68% of patients showed complete disappearance of the mass before starting neoadjuvant chemotherapy. What about MRI? We assess the MRI using the morphologic criteria. We reached complete absence of an evidence of a lesion. Here we have complete absence of the mass after neoadjuvant chemotherapy in 92%, 23 out of 25. And as regards the kinetics, we reached a complete shift of kinetic curve from type 3 curve washout curve to the type 1 curve persistent curve in 96% of cases, meaning 24 out of 25. What about MR spectroscopy? MR spectroscopy is a biochemical assessment of the chemistry of the tumor, where we evaluated the metabolites in the tumor, and the choline is a biomarker of malignancy. We measure choline before starting neoadjuvant chemotherapy, and we measure choline after complete remission. And here you can see there is complete absence of an enhancing irregular mass in the breast, and also there is complete disappearance of the previously reported choline peak after neoadjuvant chemotherapy. And among the complete responders, this happened in 23 out of 25 of cases. In 92% of cases, MR spectroscopy was able to detect complete pathological response. Here is another example showing a mass, lobulated outline mass enhancing, and it disappears in the post-neoadjuvant chemotherapy images. And also we have a very high choline peak that disappears completely in the post-neoadjuvant chemotherapy images. What about the PET-CT? You will got surprised. Before starting neoadjuvant chemotherapy, we have uptake for the 25 cases of the complete response. 24 only have uptake. The one case which was negative on PET-CT was lobular carcinoma, and it's typical for lobular carcinoma to be false negative on PET-CT. PET-CT shows absence of FDG uptake in 21 out of 24, meaning only 48% of cases after complete response. Uptake after complete neoadjuvant chemotherapy occurs in 3% of cases, meaning that we have 3 cases of complete complete pathological response and still having PET-CT uptake. But we usually measure the SUV, and the SUV of these cases was very, very low. The average SUV for active cancer is 11 for ductal carcinoma and 9 for invasive lobular carcinoma. So it's not actually a false negative. When comparing the performance of each modality as regards the detection of complete pathological response, we found that mammography detected 44%, sonography detected 64%, dynamic MRI detected 69%, and the MR spectroscopy detected 92%. Together, the MR and the MR spectroscopy reached 99%, and PET-CT accounts for 48% detection of pathological complete response. The sensitivity MRI was the most sensitive test for detection of pathological complete response, with GABA agreement more than 0.8, and with a very good negative test the agreement for the false negative rate was 0.9. So, to conclude, based on our results, the most sensitive radiological modality to diagnose pathological complete response were dynamic MR mammography and the MR spectroscopy, but further studies using new modalities and large number of patients required to confirm our results. Thank you for your attention.
Thank you, Dr. Nagla, for your nice presentation. I would like to open the floor. Okay, for 5 minutes or more, if there is anyone who likes to have any questions, Professor Nagla or otherwise. Okay, Professor Omar.
I would like to ask, first of all, this is a great session, and it's a great idea to discuss this radiology session rather than pathology. It's more interactive. We have a lot of aspects here. I would like, my question goes to Dr. Mohsen Mukhtar regarding the role of neoadjuvant hormonal therapy. It's something that we all speak about, and there is very little data regarding it, and there is also very little gut or strength to move on and convince the patient for giving neoadjuvant hormonal.
I'm convinced if you have a postmenopausal patient that is really not fit for chemotherapy, or she's like, let's say, over the age of 65, these are the patients I would go for hormonal therapy, especially if they are ERPR positive, strong positive. Strong positive meaning if I've got a score of 6, 7 or 8 for them. Other than that, I personally don't do it. The trials have showed that it's an aromatase inhibitor, but I think it is something that we need to do more, frankly, than we are doing, because, as you said, we don't have the guts enough to do that.
This is excellent what you are saying, but sometimes we are stuck with the cases when we have a patient who's more or less locally advanced, and when we give the adjuvant chemotherapy, whether it's locally advanced, to make this optimal, or to make this mastectomy conservative. And sometimes we can see a patient, she's locally advanced, but she's urinary. In fact, I'm talking about a case that we have seen last week, ER 8/8, PR 8/8, L2 negative, PI 67, 5%. We know that in the past, or this is an advanced case, she needs to take something before surgery, but we know deep inside that we're not going to expect marvelous response in 3 months. And what we offer the patient is neoadjuvant, and we re-evaluate after 3 cycles. If we are improving, then we can continue. If not, then we will go for surgery.
Yeah.
And for those cases, maybe, we can give them the adjuvant hormonal therapy.
Yes, you can. Now, let's make a difference between pathological CR and some sort of response. Because if you give her chemotherapy, you will get response, but you're not going to get pathological complete response. So it's the same as neoadjuvant hormonal therapy, because if you give neoadjuvant hormonal therapy, as I showed you, it's still very low. Pathological complete response is still in the range of 5%. So whatever you do in terms of pathological complete response is going to be low, but giving chemotherapy is as equal in terms of transforming this patient from locally advanced into a more operable case.
Maybe I comment here, because in our routine practice, when we see a case of locally advanced breast cancer, even if she's of luminal A and everything is fine to go with hormonal treatment, none of us could have the will to go through hormonal treatment, because maybe this could be possible for metastatic disease, not for the adjuvant purpose, because I have seen many patients, they fail to achieve significant response on chemotherapy while being metastatic, and then when we shifted to the hormonal treatment after completing the treatment course, we started to have significant reduction of the mass size and resolution of the skin effects. I have a question actually also to my dear colleague and friend Mohsen. Now we are in the era of choosing what to give according to molecular signature. Do you think this would be also applied for the local management regarding the radiation therapy treatment, which patients could receive or not, especially that now we have a separate entity which is a triple negative breast cancer. Locally it has another approach rather than the other types.
We're going to need more trials to prove that radiotherapy for each subtype is different. But what we do know is that if you're going to have conservative surgery in a luminal, what I can give you, frankly, luminal A patient, especially those who are elderly, partial breast irradiation is better than whole breast, or you can spare the patient giving whole breast radiotherapy, which is better for cosmosis. The rest of the subtypes, I think we still, I personally will not push for this, but do you dictate your radiotherapy accordingly?
Till now, no, but I know a lot of trials now are underway, and we have a lot of list of panel of markers to be associated with these. Yes, this patient is going to get benefit of radiation or not. Yeah. Professor Amr. Sorry, أنا قلقت احنا قلبناها oncology.
Thank you for this very lovely presentation. I enjoyed it very much from your eminent professors. I have one question for Dr. Mohsen and one question for Dr. Ali. I can't tell the right astonished for the last 3 slides because how can you explain there is a response for patients with receptor negative?
If you looked at the trial was tell this patient to have a healthier diet, low fat intake. Now when you have a healthier diet, low fat intake, you're obviously decreasing your the metabolic process and the toxins that you're getting out of the fat in food. It doesn't have to be that this is a production of estrogen or progesterone. It can mean that it is like we've all learned, or you've got some factors like omega-3 and things like that do have some sort of cytoprotective effect. So decreasing the fat intake and decreasing the toxins that are produced by this fat intake probably is the cause for this reduction.
I think for me, this results is for survival of patients in general.
It's obviously in general, yes.
Related
to ER, PR, yes.
For Professor Ali, do you agree with me that we can, in some patients, change the oncotype by KI76 examination? Because it's technically the thing I say. In high-risk patients, if I ask is going to give therapy or not, if I found the KI76 is high, I don't need to do oncotype, I think. If there's an oncotype...
The oncotype, there are criteria for recommending the oncotype GX, among which is low
KI76.
Is ER positive, and ER positive cases are usually KI low. There is a reciprocal relation between hormone receptors and KI. The higher the hormone receptor, the lower the KI, the negative the hormone receptor, the higher the KI. Among the recommendations for doing the oncotype is, number 1, ER positivity, number 2, early stage cancer, number 3, no lymph node metastasis, number 4, which is added recently, postmenopausal, and actually the benefit from oncotype test in our country is limited because of the very high cost of this.
Some pathologists claim there is no name called estrogen receptor negative or estrogen receptor positive. Do you agree or not?
No, I don't agree. What estrogen receptor, hormone receptor negative, what positive?
Estrogen negative.
ER negative, PR positive.
Well, there is a limited number. Most of the we have a lot of cases ER positive, PR negative, and very few cases PR positive, ER negative. Okay? We do see, and all of us have seen this. And it is reported and recorded. You can have ER positivity, PR negativity. Rarely you can have the reverse, PR positivity and ER negativity, but the targeted therapy, amoxicillin, is meant for estrogen, I think.
ER positive.
Yes.
Yes. For the degradation.
Yes, yes. What is new about this is they added androgen receptors also.
This unique. I enjoy this new thing of, this is not new, but this new thing of androgen receptors. The last question, if I may, if you guide the Ki-76, as it is a population marker, do it change by the change of treatment? So if I'm doing before chemotherapy, till 70, and after chemotherapy, it may be
we can expect lowering of the Ki-67 with successful chemotherapy, because actually chemotherapy targets the proliferating cells.
So
it can
be predicted markers, not only prognosis.
Well, I don't need to make Ki-67 because Nagla will follow up with radiology and will see that the size of the tumor has diminished from 5 centimeters to less than 1 centimeter or vanished totally. So I am not. What is about the molecular profile following chemotherapy is a very well-known target. Even ER and PR may change after chemotherapy.
Can I comment something? And we have here the professors with us. In fact, according to our guidelines and to where we practice, when we perform the adjuvant chemotherapy, we stick to performing all the battery immunohistochemistry, but we redo again the Ki-67 once more again because it indicates the response to therapy. If we have a Ki-67 of 50% and we gave the adjuvant chemotherapy, and then we find it being lowered together with improvement in the imaging, together with what Professor Ali is going to say in the specimen, then we are giving it a good evaluation. I just want to comment one thing on the oncotype that you have asked and the limitations that Dr. Ali has mentioned. There is the big financial issue, but there is also a big problem in oncotype is that there is a big gray zone area. We have 3 variants, very below 18, very above 30. This is indicated, this is not indicated, and there is the gray zone in between, so sometimes it's not cost effective. So now they have established something new which is called the EndoPredict, which is a little bit more advancement of the oncotype, where there is clear differentiation between yes, give, or no, don't give the therapy.
Okay. Thank you for your attention, and by this discussion, we'll close the session and see you after.